Tēnā koutou katoa. Thanks for the introduction, and I'm sorry I can't be there. It's the first of these excellent knowledge exchanges I've had to miss due to other commitments. But I'm talking today about deprescribing to reduce polypharmacy, and particularly a novel way that we designed after InterRAI assessments to do a research in a randomised clinical trial. And I appreciate everyone's from different backgrounds who are in the room today. So I'll just walk you through all this and how we did it and why. So next slide, please. So epidemiologically, if we look at the big picture, medications cause side effects to many older people. And if we look at falls or fractures or mortality, medications are associated with large numbers of adverse outcomes in older people. And we know that certain types of medications are particularly bad, which is anticholinergics, which some of the incontinence tablets and Parkinson's medications, and sedatives, which is such as sleeping tablets, are some of the worst medications. And when we look at medications, trying to tease out particularly bad medications from other medications is a complicated dilemma when there's literally thousands of medications. But the drug burden index is one new tool that's been developed to estimate side effects of medication, or total side effects of the anticholinergic and sedative medications people might be on. And drug burden index simply gives a score of the total risk medications that a person's on. So next slide, please. So in this research, we did a randomized controlled trial, which the randomized controlled trial was designed to, first of all, in this randomized trial, we identified people after an InterRAI assessment who were on high-risk medications as measured by the drug burden index. And we wanted to assess the effect of a pharmacist doing a home review and looking at making recommendations to the GPs around reducing the dose or stopping some of those high-risk medication and comparing that with standard care. We did follow-ups 6 months after the intervention, and we really wanted to see if people, after an InterRAI assessment, if people who are on high-risk medications as measured by the drug burden index, were on less medications after the pharmacist review at the 6-month follow-up. And we also wanted to see if there was outcomes differed by different levels of frailty, whether people with low, medium, or high frailty benefited all or benefited the most. Next slide. Oh, sorry, next slide, please. If we just skip 2 slides. So one of the benefits of using the InterRAI to identify patients is that we can identify really large numbers of patients for research and randomized clinical trials, or people could use it for other trials as well. And we did the research in Canterbury, mainly Christchurch, but a little bit in South Canterbury as well. And there were 733 potential people who had an InterRAI who met the criteria. And we then screened people for different reasons, such as they weren't willing to participate in the trial, or they'd had repeat hospitalizations, or they had cognitive impairment. And after that, we managed to get 363 people enrolled in the trial, which for a trial in older person's health research in largely one city is a really high number of people. And we randomized the people to 3 categories: high frailty, medium frailty, and low frailty. And in those categories, after 6 months, and we compared those with the pharmacy intervention compared to no intervention. And after that, we did a follow-up medication review. Can you just go back to the previous slide? So overall, we got a large number of people in this trial. In the control group, there were 179, and in the intervention group, 184. The average age was about 80 in both groups, and as the standard in InterRAI assessments in New Zealand, about 2/3 of the patient were female. In Canterbury, it was harder to recruit Maori and Pacific patients compared to the normal population, and recruitment was below 3% in each of those categories. Majority of patients were of European descent. Go ahead 2 slides, please. This here represents the drug burden index at baseline medication review for everyone who participated in the trial. And there's on the bottom axis, on the x-axis, it's a range from 0 to 4, and on the y-axis is the number of participants. So everyone on the trial had to have a baseline drug burden index of over 0.5. And as you can see, the majority of people had a baseline drug burden index of between 0 and 1. And a few people had a drug burden index of greater than 3, and only one person had it greater than 5. So it's mainly skewed. Most people had a drug burden index between 0 and 1.5. Next slide, please. One of the difficulties about this study is that we had to sort of navigate the challenges of COVID. The study commenced in 2018, and it was held up by COVID, and we continued as we could with different lockdowns and a whole lot of different workarounds for visiting people in their homes and some of these elderly, vulnerable people. But we managed, I think, even though we got the trial completed, and we had to complete it on time due to various funding constraints, COVID undoubtedly interrupted the trial, and we analysed the results as a group, and then we also analysed them pre and post-COVID. Next slide. So this here is a summary of the outcomes, and on the bottom is the difference between the intervention and control with change in this drug burden index. And if the results are out here, it's a favourable outcome. If it's on this side of the line, it's an unfavourable outcome. The overall change was essentially 0. And basically it was saying that in the intervention, pharmacists reviewing these high-risk patients who are on drug burden index medications and sending recommendations to the GP made absolutely no difference overall. We broke it down, though, into different sub-analysis. And this here is the effective lockdown. If we look at our pre-lockdown data, there was certainly a trend towards some impact, some favourability of this trial where the pharmacist review was leading to improved outcomes. It doesn't reach statistical significance, though, because it crosses this line of 0. After COVID is the result here, and there was it was tended towards an increase in medications for these people, and we partly wondered if it was due to some people after COVID being prescribed more anticholinergics and sedative medications because of the stress of COVID and the isolation and other effects that it caused. We also looked at our results by location, and we started off in South Canterbury DHB, and there they have high levels of polypharmacy prescribing according to the National Atlas of Polypharmacy. And the results in South Canterbury definitely led to an improvement, showed an improvement in favourable outcomes in terms of people who had the intervention had less levels of anticholinergic and sedative medications. But because the numbers were so small, it doesn't reach significance. And we had to stop Timaru because it was actually quite complex to run a trial down there when we didn't live there, and for various reasons. In the top line here, we look at the impact of the deprescribing intervention in different levels of frailty, people with low frailty, medium frailty, and high frailty. And in low frailty, there was also a trend towards the pharmacist deprescribing intervention, improving outcomes. But again, this crosses 0. The result was unfortunately non-significant, and we can't say it's a positive result. You can perhaps say there is a trend towards being positive in the low frailty, but the opposite was happening in the medium and high frailty patients. Next slide. as well as the primary analysis, which I presented, which was, did the pharmacy intervention have an improvement in DBI? We looked at other outcomes such as, and there was no change in ED presentations, hospital admissions, ARC admissions, or mortality after the intervention. Next slide. So in conclusion, partly why I'm presenting this today is to show you that InterRAI is a really effective way to recruit large numbers of older patients, in this case for a randomized control trial, where we were looking at the effect of a pharmacist intervention, but we recruited 400 patients, and largely in Christchurch, and this using InterRAI data to recruit patients for trials, I think, is a really important thing to consider people using in the InterRAI, and it might be to target falls or depression or an early dementia intervention. However, in this trial, looking at the impact of a pharmacist intervention for people on high-risk medications, there was no impact overall. There were some trends, but statistically no impact. I was really disappointed that COVID came in the study. COVID was in the study, and we couldn't change that. We had to work around it, but really I think it put a big barrier to this working, because GPs were not interested in following up, deprescribing at sort of stressful times, and patients often weren't going to GPs because of fears of COVID in the early 2020. So it's something we just had to work around and analyse the results from. Next slide, please. We're supported by a very large research team. Ulrich Bergler, who's there today, was part of the team, and it was great to have him as an organiser. We had a variety of GP and pharmacists on this team. I particularly want to shout out to Carolyn Gullery, who's, when she was working at the DHB, was a big support. It's really arranging and contacting these people required a lot of coordination with the DHB, and Carolyn was quite instrumental in allowing that to happen. And certainly if anyone else wants to try anything like that, I think I'm happy to talk to them about the processes to help make it easier. Also, we were greatly supported by Uri Hapari-Bolmore, who presented last year at this conference, and she was also given the Emerging Maori Researcher Award, as well as Nairi Curse. So thank you for those people as well. So given that, I'll hand it back to Sally. You're on mute still.
Thank you, Hamish. We do have some time for some questions, if there's anyone on the floor or online that would like to ask Hamish anything. Marie.
Well done, Hamish. I had a question about how many communications there were from the pharmacist to the GPs, because there's some literature suggesting that just recommending drug changes or any interventions to GPs once or twice doesn't really change things. And certainly my work trying to reduce antipsychotic prescribing in a large care home group has been fraught with no change. Need a different approach, I think.
We worked with Dee Mangan, so we had the GPs were informed through their newsletter that this was happening, and we did send a letter to them outlining suggestions for change. We got some sort of qualitative feedback, and a lot got the letter, and they were considering it. I think part of the reason this didn't work, as we look retrospectively, is that Canterbury has quite good polypharmacy education through Pegasus, but it is one thing, and I think you're right, one letter, particularly during COVID, sort of not in their workflow, not related to their electronic patient records, may have been part of the reason this didn't work as well.
Thank you, Tim.
Thanks, Hamish. Tim here. I work at MSD in elder abuse. Just a quick question on the use of the as a recontact panel, I guess, effectively. Sorry, I'm thinking of a large survey, but essentially you've gone back and talked to the older people who were contacted through the InterRAI. Did you actually interview them, or were you just using their data? Sorry, I wasn't completely clear.
No, we did, and that's a good question. people who had an InterRAI through the Canterbury District Health Board, the Canterbury District Health Board wrote a letter to them and said,
Right.
are you interested and happy to be contacted? And then if they responded to that letter, they passed on the details to us and we contacted them. Does that answer your question?
Yeah, that does. Yeah, it's a complex thing, identifying that sample group, and yeah, thank you.
Thanks, Karen. We've got time for a couple of questions.
Sally is asking which frailty assessment was used.
That's a good question. From the InterRAI data we have InterRAI actually has many questions that almost map onto the Edmonton Frailty Scale. So we had a derivation of that which we developed from the InterRAI. It's not the same as the InterRAI, the Edmonton Frailty Scale, but it's a derivation of that.
Natasha is wondering, would you look at doing this kind of study outside of Christchurch so that we have a better picture of Māori Pacific Island older people problematic polypharmacy?
Yeah, I think that's a really good point. We would love to do it again. I think Christchurch wasn't the best city, definitely because of that, and we could have looked at doing it. If we could apply again, we'll do it at another centre, which has a higher Maori, Pacific and Asian population. Also, Timaru, we found, I think it was working in Timaru partly because they don't have so much GP education, and there's certain high-risk areas we know, such as Otago, South Canterbury and Taranaki, that have high deprescribing rates. It may have been better to do in there.
And last one, the rest will go to our spreadsheet to ask you later. Thanks, Hamish. I'm interested to know, how does the study contain the patients from the InterRAI?
How does the patients contain the, how do you obtain the patients from an InterRAI or contain? I'm not quite sure.
Contain is the word that's in the question, so sorry.
I think that's getting at might be obtain, in that we actually went through the DHB, and the DHB kindly sent out letters to people who had an InterRAI and offered them to see if they wanted to be part of the study. And if they returned that letter to the DHB, then they passed them on to us as the university, and we did the research through there. So it was a bit of a mixed institution. It was two institutions. It was quite complicated to arrange.
That's brilliant. Thank you very much, Hamish. And there are other questions, but we will put them, we'll get those answered for you online.